Okay, dear Chairperson, thank you for the kind introduction. It is my great honor to have an opportunity to present my research finding in AHS research meeting. I would like to introduce my research outcomes. Some of them have been recently published or under revision. Okay, my disclosure. Let me first talk about the history and role of digital twins. So actually, in silico modeling of atrial fibrillation has already been reported in 1964 by Gordon Moore and his group. Afterward, various human atrial cell models have been introduced in succession. The most widely used human atrial cell model is Krumanscher-Ramirez-Natel model, and the computing time issue was critical, but we overcome this speed by parallel computing technique using the NVIDIA's GPI. It is almost 100 times faster than MATLAB. Okay, this is synopsis our QBR digital twin model, reflecting personalized anatomy, histology, and electrophysiology. So at the beginning of AF ablation procedure, the clinical team acquires voltage activation maps and send the EGM data to core lab. And the core lab integrate clinical map to AF digital twin modeling fibroindentation and local fibrosis. Then we induce virtual atrial fibrillation in computer to localize AF driver. It takes about 20 minutes for computation. So what is the advantage of utilizing AF digital twin? First, unlike clinical point-by-point map, we can view the entire chamber-centric map and chamber-centric wave dynamics. Second, you can test any kind of various interventions under the same condition control. Third, virtual enterosmic drug test or genetic susceptibility test is possible. So clinically, the most advantageous thing is that you can predict your clinical outcome in advance. I will start by introducing the most recent digital twin research regarding restitution. This is concept of restitution. We know the action potential duration shortens as heart rate increase. In this graph, x-axis stands for diastole interval and y-axis stands for action potential duration. So APD changes higher degree at the exact change of diastole interval at the condition of higher restitution curve slope. Therefore, Smax, the maximal slope of APD restitution curve, is critical for repolarization heterogeneity. Restitution is a dynamic APD heterogeneity reflecting the AF wave break vulnerability. So, for example, at easy slope of Smax condition, long coupled ectopy converges to the restitution curve and restores to the sinus rhythm. However, at higher Smax condition, short coupled APC cannot converge to restitution curve and eventually induce the breakup of wavelet to fibrillation. And restitution originally was a single cell electrophysiology measured by glass microelectrode. However, by utilizing digital twin, you can generate high density restitution map of a 0.4 million node with cell size. Okay, in this study, we analyzed 323 patients who underwent the digital twin restitution map, AF ablation, and regular rhythm follow-up. We excluded 32 patients with significantly high scar burden, over 40% of left atrial surface area. The reason of this exclusion was those patients exhibited a completely different electrophysiology and Smax distribution acting as outlier. Consequently, 291 patients were included in this analysis. First, we performed the virtual atrial fibrillation induction test using digital twin. We used the exactly same virtual ramp pacing protocol as in EP lab, and we defined the sustained atrial fibrillation as cases maintain atrial fibrillation for longer than 22 seconds. And after median follow-up 23 months, the recurrence rate was significantly higher in patients with virtual sustained atrial fibrillation, and the rate of recurrence in form of atrial fibrillation was particularly high in this patient with sustained virtual atrial fibrillation group. We also conducted a cluster analysis for the value and distribution of restitution Smax and divide them to 4 different groups. First one, overall low Smax group. Number 2, overall high Smax group. Number 3, average homogeneous Smax. And number 4, average heterogeneous group. So we have summarized the Smax distribution and virtual AF inducibility and clinical AF recurrence according to 4 groups. And overall high Smax group shows by far the highest virtual sustained atrial fibrillation rate. And the clinical AF recurrence rate was also significantly higher. So mostly recur as atrial fibrillation. This is Kaplan-Meier curve, depending on Smax clusters. Virtually measured Smax and its distribution had a consistent influence on clinical recurrence after AF ablation. Therefore, patient-specific digital twin-derived high-density virtual restitution pattern and virtual AF sustainability were closely associated with clinical atrial arrhythmia recurrence after catheter ablation in this study. Okay, next topic is digital twin-guided AF rotor ablation. The QBI-AF trial is a randomized clinical trial on the persistent AP ablation for stable rotor involving 4 participating institutions in Seoul, and total 304 persistent AP patients were compared with one-to-one randomization manner between PBI plus digital twin-guided stable rotor ablation group and empirical PBI group. And the stable rotor was defined as a phase singular point that remained within 1 centimeter diameter at least for longer than 2 seconds. And this is the ablation targeting stable phase singular point, which was projected to real-time 3D Navix map. And eventually, you see the termination during real-time rotor ablation. This is a procedural overview I already introduced before, and clinical LA activation bipolar voltage map were sent to the core lab. And in the core lab, patient-specific digital twin determined the location of a stable phase singular point. And this stable PS map was then returned to EP lab to guide additional rotor ablation in digital twin guide ablation group. And the baseline characteristics of 2 groups were well matched. Median age 62, female 20%, and 70% were long-standing persistent AFib. Actual stable phase singular point target were observed in only 43% of these persistent patient group, and the median number of rotor was 1 or 2. Due to small number of target rotor, there was no difference in total procedure time and total ablation time between 2 groups. On the other hand, AF recurrence shows a 62% low recurrence rate with statistical significance after additional stable rotor ablation. And the location of stable rotor was highest in the perimitral area and followed by septum. Regarding secondary outcome, there was no difference between 2 groups in pure AF recurrence, antiarrhythmic drug use, cardioversion, and complication rates. Therefore, in this study, we demonstrate that the digital twin-guided stable rotor ablation provides an additional benefit for rhythm outcome compared with PB isolation alone. Okay, now we move forward to artificial intelligence. Can you guess whether the owner of this ECG is male or female and their approximate age? Actually, I never learned or attempted to determine age or gender from ECG alone. But AI has accomplished this difficult task. The reason I'm interested in AI ECG agent sex is that first, simple indicator like agent sex are relatively easy to validate in multiple large ECG cohort. Second, unlike other phenotype, they have a small impact on AI training data. So age is major risk factor for cardiovascular disease, and old adults chronological age is less likely to align with biological age. It is because the increasing biological heterogeneity among individuals. What about sex? There is substantial evidence on sex differences in their impact on atrial fibrillation. Across various countries, the prevalence of atrial fibrillation in women is typically lower than men. So women also exhibit different electrical and structural characteristics in heart. While many AI ECG algorithms have shown remarkable accuracy in disease detection, their generalizability remains a key challenge. This is partly due to the ethnical and regional difference in population characteristics. It also reflects variation in the diagnostic criteria across cohort. To address these limitations, we focus on developing and validating AI ECG models that predict age and sex. These two fundamental, universally applicable demographic traits, rather than attempting predict disease outcome across heterogeneous population. Therefore, we use the multitask learning model, MTL model, to simultaneously predict both age and sex from a single ECG. To test this, we develop and validate an AI ECG model that predict age and sex using data from three multinational cohorts. And our MTL model performed well in predicting age across three validation cohorts, showing actually better correlation between chronological and biological age when compared with Lima's previous model. And at this time, the model's accuracy and AUC were quite strong. So my group recently reported the finding on association between AI ECG, age sex discordance, and atrial fibrillation. When the age gap, ECG age gap between ECG age and chronological age was over 7 years, AF incidence was significantly higher, particularly under 65 years old. And this is another study. We found the instance of atrial fibrillation was significantly higher when there was AI ECG sex and biological sex discrepancy. When performing a quartile analysis combining the AI ECG age gap and sex miscalculation, the instance of atrial fibrillation was highest in the population with large ECG age gap and sex discordance. We also reflected the major adverse cardiovascular event with consistently higher AI ECG age gap and sex discordance in three different large cohorts, including overall 0.2 million patients. ECG age gap shows a significant correlation with dementia risk also, and the risk was particularly high in vascular dementia and post-stroke dementia, and it was consistent in the group with ECG sex discordance. This is the AF ablation data cohort, and AI ECG age and sex also predicted power for recurrence after ablation. The recurrence rate after AF ablation was significantly higher in patients with age gap over 7 years, and recurrence rate was significantly higher in women who shows the ECG sex discordance, but not in men. So in this new study, we compared the AI ECG before ablation and 3 months after ablation. AF recurrence rate was the highest in the patients with increased ECG age and elevated sex discordance. So how can digital twins be integrated with artificial intelligence? The biggest weakness of current QBR digital twin model is that it requires invasive high-density mapping data. Since we already have a robust database over 1,000 high-density mapping based on digital twin, now we are training AI using data consistent map that can be utilized AF ablation by only non-invasive data. We are training AI model that predict invasive electroanatomical map using ECG and CT and clinical profiles. I hope we will be able to expand the application of digital twin in AF ablation practice using only non-invasive data pretty soon. So this is my conclusion. High-density map integrated digital twins accurately reflect AF electrophysiology and demonstrate the prognostic value of a virtual AF inducibility and restitution property. And digital twin detected stable AF rudder ablation improves the outcome of persistent AF ablation. AI ECG age gap and sex discordance significantly predict AF instance, MACE, and the post-ablation AF recurrence. With the integration of AI into digital twin, predicting the AF electrophysiology without invasive mapping data is not far off. Thank you very much for your attention.
That was great talk. I enjoy
Thank
it.
you.
Professor Park, with the QVIA, I see the turnaround time about 20 minutes or so, right?
Yeah.
When you have to send the data out to the core
Mm.
lab. What do you do in the meantime? So you do the PBI?
Yes. During that time, we
You,
do PBI.
so 20 minutes and then you come back and ablate
Yeah,
the rest?
we try to shorten the computation time in the post-field era. Yeah.
So it will, oh yeah, because that will take much less time. Well, I guess that's one of the question I have. I guess now with the pulse field, it seems like the area that we might be able to ablate a larger area. Will it make these findings a little less useful, or you think it'd still be good? We'll just add it with the point by point ablation. What's your thought? What's everyone else thought on it?
You mean the rotoablation?
Yeah.
I think because actually there is a two different theory explain the AF maintenance mechanism. Number one is multiple wavelength hypothesis, and the other one is focal source hypothesis. And the stable rotor that supports the focal source hypothesis. In our database, among the patients with persistent AFib, only 43% of patients shows their stable rotor after PB isolation. All these digital twin was done after PB isolation. So I think half of them actually doesn't need the stable rotor mapping. And also the number of rotor is less than 3, 1 or 2. So that's why the ablation point is just several, and this procedure did not increase the procedure time or ablation time. So I would like to try the more focused extra PB ablation.
Can you try cafe? It works.
Oh yeah, we are analyzing comparing and try to co-localize the low voltage area as Minglong Chen is doing, and also the top area. Yeah, that's interesting. And thank you very much for your comment.
We now have a question. Yeah. CK, go ahead.
Just a follow-up question. Would you be extending this study, the QVIA study, to point by point, say PFA or dual energy, because PFA is so readily available with the dual energy? Would that be a consideration?
Yeah, you read my mind. Actually,
fantastic.
Great. I'm plan because the technology is changing too quickly. So we just finished this RF the mapping the RCT, and we are keep continuing the redo cases. And now we are planning the protocol utilizing PFA. And the good news is now we can integrate this QVIA map to our currently using the commercialized 3D mapping system. So we can trace the location of a stable rotor, and we knew where we are ablating in real time.
Thank you.
Okay, we now I have a question. So wonderful talk, very friendly. But you mentioned that you have 43% of the patient they have very stable, very fixed rotor. So can you characterize the electrograms, local electrograms during AF map, because you do a high density map during AF? So if we can find the features or the very specific characteristics of these electrograms, then finally, I think we can do the rotor map and ablation in a very simple way.
Right, exactly. So we got the exactly same question from the reviewer, and now is that in the process of second revision. And as you mentioned, and the consistent year hypothesis, the most of those stable rotor is scarboardism of atrium.
Scarboardism. Okay.
Yeah, I'm not sure that we can use that terminology in atrium, but the consistent year hypothesis always there is a close relationship with substrate changing. So probably the scarboard zone change some conduction velocity restitution and APD restitution, more vulnerable status of maintaining drivers. But our focus is just localize, more minimize the ablation for the extra PB focus.
Okay.
All
Thank
right,
you.
great. So
Okay,
I
thank
guess
you.
next, Dr. Jiang will introduce the next speaker. Dr. Park, I'm afraid to send you my EKG now.
Thank you. Thank you.
Okay, thank you, Dr. Park, for the outstanding presentation. And now we need to move to our second topic. If the previous talk represents the frontier of technology, and our next topic addresses very important clinical challenges that puzzled EP committees for nearly 2 decades. Let's welcome Professor Minglong Chen. Minglong Chen is the director of cardiac electrophysiology of the first affiliated hospital of Nanjing Medical Hospitals, and he also is our national representative of China to APHIS. And Minglong Chen's topic is beyond PVI, substrate modification strategies for persistent AFib. Welcome, Professor Minglong Chen.
Thank you, Dr. Jiang. So good afternoon, dear colleagues, and thank you very much for your kind invitation. So my topic is beyond PVI, the substrate modification strategies in persistent AF ablation. So I think PV isolation is very essential for all types of atrial fibrillation. But the question is, at which level we need to isolate the vein, so PV ostium, the antrum, or out of the antrum? And the other important question is how to make it permanent. So antrum isolation is clearly evidenced by previous studies. So you can see that in the early studies, so PV isolation at the ostium level, the success rate for persistent AF is only around 20%. But for the antrum isolation, the success rate is increased to over 50%. So from ostium to antrum level, the success rate was improved by 30%. So our early study showing that the even in paroxysmal AF, the antrum, so at the antrum area, this is the control group, the SVT patients. You can see that at the PV antrum area, the conduction is low, and also the electrogram is fractionated, and also with the dispersion of the refractory period within the pulmonary veins. So with this, we define the concept of the electrical entrance. So PV isolation can not only be based of the anatomic entrance, but should be based on the electrical entrance. But for persistent AF, this is very much challenged by two ways. One is how to make the PV isolation permanent, and the other way is because for persistent AF, the substrate is very extensive at the left atrium body. So the first challenge now can be overcome by the lesion quality control. So with AI introduction, the lesion quality control, PV isolation for persistent AF, it's only PV isolation. So the 1 year success rate can achieve 2/3. So this is a very high success rate only done by PV isolation. But the question is, who is the PVI responder? Because we know that less than 10% of the patients during PV isolation AF terminates. But we know in our heart that only PV isolation can achieve the success rate of as high as 60%. Approximately 50% of the patients actually they receive excessive ablation. And so this is the first question. The other important question is if we do additional ablation in the left atrium, where to go? And what are the true maintaining substrate? So this is electrophysiological substrate, like Professor Park mentioned with the stable rotor, and also is it the pathologic substrate? So with the previous studies, you can see that these are the previous mentioned electrophysiological substrate during AF: coffee ablation, linear ablation, and stepwise ablation, posterior wall, rotor mapping, and ablation. But the pathological substrate, the low voltage area, this is the indirect substrate reflecting the atrial fibrosis area. And this is the MI-guided fibrotic tissue. So this actually are the two histological substrate. So hopefully, let's go over the concept of the complex fractionated electrogram. So in the initial studies, this is the definition of the coffee low. You can see that here, low voltage, peak to peak bipolar amplitude. This is low voltage, and fractionated high frequency. So this is the definition of the coffee. But actually, in the real practice, only based on our vision, it's hard to define the true meaningful coffee points. So with the new versions of mapping tools, like mentioned by Professor Park, that using AI or using digital twin, we can find true meaningful coffee areas. So maybe we can increase the final success rate, but the only studies only based on our vision. So the coffee ablation cannot achieve the positive contribution. And how about the linear lesion? Linear lesion, this is the true linear line. But actually, when we do the linear lesion, the patient is breathing, the heart is beating. Often you are creating a narrow band. So at the edge of this narrow band, these are the half lesion area. A half lesion often is arrhythmogenic. And also linear lesion, you cannot achieve, not very often, the bidirectional conduction group. You can sometimes leave gap there. So these 2 points are the pro-arrhythmic, the substrates for the PV for the linear lesion. Therefore, the linear lesion actually do not contribute too much to the overall success rate. So these 2 ablation strategies were proved by STAR-F2 that the final ablation result was not improved. On the contrary, the overall success rate was reduced. You prolong the procedure time, but you actually do not increase the success rate. So how about the box isolation? Box isolation, histologically, I think box isolation is meaningful, but actually their practice, the result is neutral. So the Catheter study also proved that. So the box isolation and no box isolation, the final result is quite similar. Even the very recent, the Cornerstone AF trial, they are using cryo to do a posterior wall ablation, and you can also see that the success rate is quite similar. Rotor mapping and ablation. So first, the rotor mapping is very challenging, and also the result of rotor ablation is very inconsistent among the centers, and the meta-analysis showing that rotor mapping and ablation prolong the procedure time by 1 hour, but you can see that the success rate was lowered. So this is even lower than only PV isolation. So at that time, the mapping of the rotor area and also the ablation tools to suppress the rotor area was very challenging. So the substrate modification, where to go? So I think the atrial fibrosis contributes to the maintenance of atrial fibrillation. So this is the persistent AF. You can see the heavy burden of the fibrotic tissues. And when the interstitial fibrosis occurs, you can see that the coupling interval, the coupling, cellular coupling was diminished, and also promote the anisotropic impulse propagation, and also the atrial activation abnormalities. So AF becomes AF have two concepts. One is AF becomes AF because of electrophysiological remodeling, means that the refractory period of the atrial myocardium tissue was shortened. This can help the atrial fibrillation persistent. And the other is the atrial fibrillation can become atrial fibrosis. Atrial fibrosis can help to maintain atrial fibrillation. So this is the concept of atrial cardiomyopathy. Actually, the atrial fibrillation represent the electrical disturbances of the atrial fibrosis or atrial cardiomyopathy. So Dr. Marushi in the olden days did a very elegant study that using MI delay enhancement. So they characterized their patients with AF burden with 4 stages. But whatever you do, the final success rate is only determined by the extent of the atrial fibrosis. But then he conduct a randomized clinical trial based on the MI detection of the atrial fibrosis, but the final result is neutral. This is because the atrial fibrosis detected by MI often reflects the transmural. This is the 3-dimensional atrial fibrosis, the epicardia, the intramural, the endocardia, but ablation often is only target the endocardia. So based on these thoughts, our thought is that atrial fibrillation should share the same or the common mechanism with the pathological VT. You can see this is pathological VT, the atrial, fibrotic tissue here, low voltage is here. And when we do substrate modification, most of the clinical VTs can be suppressed. But the persistent AF, also we can classify those persistent AF into idiopathic. This is only PV dependent. And also the pathologic, this is the working between the PVs and also the disease left atrium. So we should do PV isolation plus substrate modification, but this substrate modification is based on the disease tissue areas. So our only study define the voltage areas. So this is the dense scar, the low voltage area, the transitional area, and the healthy area. So based on our high density mapping tools. And our only study showing that when we cardiover the patients into sinus rhythm using high density map, we can find the scar area, the transitional area. So look at the electrogram recorded, but this is recorded during sinus rhythm. You can see multiple components, and this is the complex atrial electrogram. But this is, please bear in mind, is the electrogram recorded during a sinus rhythm. And as compared with the stepwise approach in our center, so as the historic control, you can see that stabilizer approach is superior to the stepwise approach. Then we did a randomized control trial. So in this trial, the trend is very clear, but the final difference is not statistically significant. But you can see that the procedure time is shortened by almost half an hour, and IF delivery time is shortened by 15 minutes. But the final success rate is not sacrificed. So this may be the problem of the sample size calculation. And with the contact force catheter, and we did stabilizer 2 study. And in this study, also, even though the final success rate is neutral, but you can see that those patients with substrate and those patients without substrate, the success rate is 24% difference. And in the control group, in the study group and the control group, you do substrate modification and you don't do, the net difference is 9%. And our stabilizer 3 trial is focused on the senior patients with paroxysmal atrial fibrillation, and those you do and you don't do, the success rate is quite different. So these are the results from other centers. Here is the Leipzig results. You can see that substrate modification as compared with not do the modification, the result is quite different. So the ERASE trial, you can see that the PV isolation plus substrate modification also showing a positive result. The very recent Substrates AF trial, you can see that this is a large sample size AF patients with substrate, but you can see that the trend is clear, even though the statistically difference is not achieved. But you can see that the AF ablation, the AF control rate is higher as those you don't do substrate modification. But this AF control rate may be diluted by the after atrial tachycardia occurrence. So this is the subgroup analysis. Those patients with very enlarged left atrium, the patients is benefited from substrate modification. So this is our thought that patients with healthy left atrium, you only do PV isolation. With moderate or the very, so this is the minor, this is moderate, you do substrate modification plus PV isolation. But extensive substrate patients, so actually they are not non-beneficial patients from the AF ablation. So these are the case examples. The healthy left atrium after PV isolation, you can see the voltage. This is bipolar voltage, and also the unipolar voltage. Both definitions are normal left atrium. So with these patients, if you can do permanent PV isolation, the success rate is very high. But look at this case, you can see those patients after PV isolation, during sinus rhythm, you can see extensive substrate, and also you can see the complex electrograms with the planetary map at the left atrium. So then we will do the substrate modification, but you cannot target everywhere. So we do the substrate-based anterior line ablation and also substrate-based posterior wall line ablation, and also we will extend the right ring to this low voltage area to include all these areas. And this is the final check of the linear bidirectional conduction block. So we put the pantry going astride this line, and you can see at the both sides the time difference of the electrogram recorded during sinus rhythm. When you're pacing at one side, you can see that the conduction can only going around the mitral ring to conduct to the other side of this line. Takes a very long time. So this is one directional block. And posterior wall line, also the pantry is going astride the line. You can see the long double potentials, but when you are pacing from posterior wall, you can see that the pantry 1, 2 here at the anterior roof, the activation is very much delayed. So finally, let's go over the very latest expert consensus. So these are the class 1 recommendations. If you do line, you should achieve bidirectional conduction block. And the simultaneous non-PV triggers, you should do in the de novo procedures. And if the mitral flutter cannot be terminated by endocardial ablation, you can do mitral vein ethanol infusion. So these are 3 class 1 recommendations, but these are the class 2 recommendations. One is low voltage area, and the other is the mitral vein infusion in any kind of the atrial fibrillation patient. And then the non-PV trigger, but this non-PV trigger is stimulated by the drugs and also the posterior wall isolation, but it might detect fibrotic area ablation. So these are the indication for the AF ablation. So ladies and gentlemen, the take-home message, high quality PV isolation is very essential for all types of atrial fibrillation. And high density voltage map during sinus rhythm can potentially identify patients with the with the atrial fibrillation, but they only require PV isolation, and in the de novo ablation procedure, you don't have to go to any other areas. And the personalized substrate modification during a sinus rhythm map maybe can improve the outcomes of the selected patient, but we need to have more evidences to support that. But the new energy sources and advanced mapping tools, mapping techniques will reshape our future ablation strategy remains to be explored. Thank you very much for your attention.
Okay, thank you very much, Professor Chen, for such an insightful and thought-provoking presentation. And Professor Chen reviewed all the strategies for the persistent AFib and reviewed the stable ASTAR journey. I think stable ASTAR is represent one of the most powerful contributions from Chinese EP doctors to the global stage. So I'd like to use our discussion time to explore more further discussions with Professor Chen and our panelists. So I have two questions for you, Professor Chen. One is that for the substrate mapping, do you think which is maybe more much precise? Like I mean the voltage during the sinus rhythms and the voltage during the AFib. And the second question is that because from the stable ASR2, the long-term outcome is without a significant difference between two groups. Do you think in the PFA this year we have the PFA energy? Do you think we have any chance to reduce the procedures? Thank you.
Thank you very much for your question, Dr. Zhang. So the first question is the substrate definition during sinus rhythm or during atrial fibrillation. So I think the sinus rhythm, the organization of atrial myocardial fibers is orientated to sinus rhythm activation. So I think everybody has this experience that when you put your catheter in left atrium, you stimulate the atrial premature activation, and you can see that the electrogram is disorganized. So actually, the sinus rhythm can reflect the true disease area, the true normal electrogram. So we prefer to map the electrograms, the substrates, the voltages during sinus rhythm, not during atrial fibrillation. But our recent studies showing that there's a very close correlation between the definition of the low voltage areas. But if the definition of the low voltage area during atrial fibrillation, so the definition is around 0.25, but the sinus rhythm voltage definition is 0.5. So if you have different cutoff value of these two mapping backgrounds, so the correlation is very real. But the key point is that, like Professor William Park represent in the maybe the bodism is also very important. So some of the rotational activation areas are at the body, the bodism of the low voltage area. So this is why in our stable SR approach, we also emphasize the transitional areas. So this is one question. The other question is regarding the PFA map, PFA ablation. So currently we do not have the evidence of the PFA ablation in the left atrium body, whether they can create transmural and permanent lesions. So we don't have the evidence. Maybe this is the our future study direction. So we try to prove that maybe with the animal studies, with the clinical studies, we can prove that maybe PFA ablation can achieve the true permanent bidirectional linear lesions and also the permanent substrate separations.
And thank you. Do we have other questions from audience? Okay, maybe we need to move to the next topic. I'd like to pass the floor to our next moderator, Professor Yu Meixue.
The next is Lu Zibin.
Lu Zibin 来了是吧？Sorry. The next moderator is Professor Zhibin Lu. Professor Lu, please.
Yeah, thank you. The next speaker will be King Chi Hong. I'm so sorry for the wrong pronunciation. He is the director of cardiac electrophysiology and pacing. His topic is about the PFA ablation for atrial fibrillation. Please.
Thank you so much for the kind introduction. It's a pleasure to be speaking at this forum to share with you some of our experiences using pulse field ablation for atrial fibrillation. I present this on behalf of my team in Singapore at National Heart Centre, Singapore. This is the global evidence. We know that PFA or pulse field ablation has taken the world by storm and it has been utilized in many geographies. And the meta-analysis suggests that using PFA, it is non-inferior to thermal sources like cryoablation or radiofrequency in achieving acute PVI. Now, it is found or it is reported and observed that PFA is slightly superior to achieve first-pass pulmonary vein isolation. It is noted in various publications that the arrhythmia recurrence is slightly lower. The phrenic nerve injury, pulmonary vein stenosis, or esophageal complication is almost non-existent compared to radiofrequency ablation. And that has an impact on procedural time, shortening it significantly, especially if we use a single shot device. As with new technology that comes with a larger sheath, there is an increase in cardiac perforation or tamponade, probably tied to the learning curve with such new technology. And the fluoroscopy time goes up because the new or the Boston Scientific FARAPulse system, which came into the market, the first mover for pulse field ablation, is largely a fluoro-based system. In Asia Pacific, it's been reported, 100% acute PVI success on 2 Japanese studies, and none of this were observed in a series close to 387 patients. There were no strokes, no TIAs, no renal injuries, no tamponade in the Japan Multicenter VARIPulse registry study. Now, it gives me great pleasure to present to you my experience at Singapore. This is a small center, and this is the PFA volume since it was available in October 2022. It should really replace RF in 2024. And in 2026, we anticipate a continued increase in the use of PFA for AFib ablation. This is the main cohort, a largely young cohort, age 61 years old, preserved EF or more, or 55%, largely men. 2 out of 3 were men. 3 out of 4 were paroxysmal atrial fibrillation. Majority do not have any structural heart disease. About 40% or 45% have hypertension. And we utilize PFA in 10% of redo AFib ablation. A quick look at the procedural characteristics. 3D mapping was used in all patients. Pre-procedural imaging comprised 40% underwent CT or MRI to assess for left atrial appendage clot and the anatomy of the pulmonary veins. About 60% underwent a TEE prior to ablation. If the FARAPulse catheter was used, most of it utilized, or almost 100% utilized a smaller profile FARAPulse catheter of 31 millimeters. The procedural characteristics are as such. Procedural time, mean time about 2 hours. Fluoroscopic duration about 25 minutes. 3 out of 4 underwent general anesthesia for this procedure. only 1 in 4 underwent sedation and deep sedation for that. And these are the indications. 63% had atrial fibrillation. Another 1 in 3 had atrial fib and flutter, and others comprise of less than 4% of the cases. If you look at the energy and catheter strategy, PFA was utilized only in 78% of patients. RF or radiofrequency catheter was used in addition to PFA in about 21% of patients. We had the opportunity to introduce Pulse Select and VeriPulse subsequently, but as we've been an early adopter for VeriPulse, 95% of patients underwent VeriPulse PFA for AFib. And for VeriPulse, the mean applications were about 59 for all cases. If it's PVI only, mean application of 40, just 41.7 or 42 application for those who underwent PVI only. Now, there is a learning curve. A learning curve can be described in procedural time and fluoro time as a surrogate marker of learning curve. I present to you our center's data of those who use cryo. This is in blue will be the procedural time for cryo. In red will be the fluoro time for cryo. And if you see visually across, PFA started with a longer procedural time, but as we continue to adopt it, the procedural time matures or stay steady around at up to about 2 hours mean, whereas the fluoro time does come down to about 15 to 20 minutes for most cases. And the procedural time tends to go a little higher subsequently because we tend to tackle more complex ablation subsequently. Wow, what do we ablate? This is a slide showing the ablation strategy for this group of patients. PVI only, in these 666 patients, only 32% underwent PVI only. So 2 out of 3 patients underwent a PVI plus ablation strategy, of which posterior wall was ablated in close to 70% of patients who underwent PVI plus only. If they were found to have atrial flutter of the CTI type, either pre-procedure or during the procedure, the CTI was ablated, and more than half utilized an additional radiofrequency ablation catheter. Just slightly less than half underwent CTI ablation using the existing PFA catheter. If mitral isthmus flutter was detected or confirmed, this occurred in close to 13% of patients. We tried initially PFA in 93% of patients, and then just under 20 underwent additional RF ablation. SVC isolation was performed close to 28% of patients in PVI plus strategy, and this is the numbers that we have thus far. A quick look at the efficacy outcome. If you look at all costs, or rather all patients, at 1 year, freedom from flutter and fib was about 87.5%. This is the median follow-up up to 458 days. The freedom from AFib or flutter is about 84%. Now, if we look at whether it's paroxysmal or persistent atrial fibrillation, those who had paroxysmal tend to have a better outcome. The freedom free of atrial fib in the paroxysmal atrial fib group was about 88%, whereas those in the persistent group was about 84%. Now, how does this compare to what we see in the literature? Freedom from recurrence, all comers of our series of 666 patients was 87.4%. In manifest PF was about 78%. If it's by AFib type, in the PAF or PAF group, it's about 88%. Persistent AFib group was about 84%. Fairly, I think, comparable to manifest PF, 82% in the PAF group and about 71% in the persistent AFib group. in the Advent LTO 4-year trial, mainly PAF group, close to 73%. The median follow-up is a little longer because we track all our patients. And the AF type cohort in our group, 3 out of 4 were paroxysmal atrial fibrillation. Only 1 out of 4 had persistent atrial fibrillation. A little higher compared to what is recorded for or recruited for manifest PF, and Advent LTO is 100% PAF or paroxysmal atrial fibrillation. In terms of safety, there was we have a 1.7% of major complications, and we'll show you the details later on. A little higher compared to manifest 17K. All right, cardiac tamponade occurred in 1 patient, 0.15%. Other complications such as pulmonary vein stenosis, strokes, phrenic nerve injury, esophageal injury, coronary spasm or hemolysis was 0 in our series. And the reported series in manifest 17K is also close to 0 as well. These are a quick look of the complications in our series. We had 1 death. It's a patient who had inadvertent, unrecognized IBC perforation while placing the catheters into the cardiac chambers. In addition, she also had obstructive cardiomyopathy, and she died. The patient passed away about 5 to 7 days due to complications that was triggered by the IBC perforation. 1 very sick patient had VTVF arrest during the procedure requiring ECMO. 1 case of cardiac tamponade. 1 of respiratory failure post-extubation. 1 patient with pericarditis, and 6 patients with excess site bleeding or hematoma, giving rise to about 1.7%. No really complications related to ablation. All these complications are related to the invasive or interventional nature of a cardiac ablation. We also look at the redo procedures post PFA. As of now, as of March this year, we only have 15 patients who underwent redo after an index PFA for AFib ablation. This is a mean age of 62 years, 6 men and 9 women. The mean time to ATAC or flutter or FIB recurrence was about 126 days. And this is the indication for redo procedure, largely atrial flutter. 53% of this patient had atrial flutter. 20% had AFib recorded, another 20% had atrial fib and flutter, and 7% had atrial tachycardia. So we brought him to the lab, and when we have to map, we map the left atrium. And this is a reconnection or recurrence rate by site. In the 122 patients who underwent SVC isolation, there were no SVC recurrence. RIPV occurred in 12.5% of this 15 group. Posterior wall, 29% out of 15. LIPV, half in this 15. LSPV, 63% of this N of 15. RSPV is 75%. CTI recurred in 83%, and MI, if we were to use PFA, recurred in 100%. Now, compared to what was reported in the literature based on the meta-analysis, the overall PV connection rate in N equals to 15 was about 53%. 8 out of 15 had PV reconnection, which is comparable to what was reported in the literature. We noticed a little higher in our initial series occurred in RSPV compared to what is reported, a little lower in RIPV, higher for LSPV, and higher for LIPV. In the posterior wall, those who underwent posterior wall and underwent a remap, only 2 recurred. It here appears to be lower at our center. With this learning, we have modified our approach in doing PFA, taking especially consideration when pulsing the anterior segment of the left pulmonary veins, the additional pulses and post-ablation map to ensure that those areas are reliably ablated. Likewise, I think it's lower in RIPV because we in our lab, we take special care to ensure that the inferior and anterior segment to the RIPV is well ablated, whether with RF or PFA. So, ladies and gentlemen, there are some limitations to my study or my presentation, that it is a single center, it is observational, and is non-randomized. We only have follow-up data of 520 patients, which 70% of the cohort. Furthermore, rhythm monitoring modality is not standardized across all patients, but it reflects a real-world working or methods in managing our patients. Well, there is a mix of RFA as well as PFA, and that may affect the distribution of outcome to PFA alone. Of course, we will look at our prospective, longer-term follow-up to confirm the durability of these outcomes. And some learning point is that high PFA-only utilization is feasible. Favorable procedure and fluoroscopy time support efficient workflow and lab throughput in routine clinical use. Excess site bleeding remains the dominant minor complications. True PFA-specific complications were not observed in our cohort. Structured systemic follow-up will be important to capture both early and late recurrences. In conclusion, we realize or conclude that PFA is safe and effective for AFib ablation in real-world Singapore, with outcomes comparable to international benchmarks. The major complication rates were driven by vascular complication. PFA-based PVI strategies for extra PV substrate ablation are highly feasible in routine practice, and this may support a broader adoption of PFA as a first-line ablation energy across AP, EP centers. With that, thank you for your attention.
Thank you, Dr. Chen. Dr. Chen just now give us a very good topic about the efficiency and the safety of PFA, especially in Singapore. I have one question for you. In your lecture, you have 15 patients with recurrence. I found that 100% recurrence with the microannulus isolation. Can you show more data on that topic? Or do we still need radio frequency in the future for mitral annulus ablation or tricuspid annulus ablation? Thank you.
Yeah, that's a very good question and observation. We initially used PFA for mitral isthmus ablation. With the data that we have, we no longer just use PFA currently. If we were to ablate the mitral isthmus, and if we do use pulse field ablation, we would do additional ablation with radio frequency as of now, for reasons as stipulated by you. Number one, the transmurality in the area via pulse field ablation may be inadequate, and I think that's a class effect. Number two, we may have to ablate within the CS, and hence radio frequency is the most utilized energy for that purpose. The areas over there are thick, and we know epicardial breakout is common. So with this learning, we would augment PFA with RF for mitral isthmus ablation. But I believe in the future, it's the same as radio frequency ablation. In the past, we underestimate, for example, the power delivered, the contact force, as well as the duration, isn't it? All these things are important. So I believe in the future, the technology should mature to provide contact force in that area. Maybe there is an ability to vary the voltage delivered for PFA, equivalent to higher volts, as in higher wattage for RFA. Okay. And the waveform to optimize and predict reliable, durable lesions. I think that's the future. But as of now, the short answer is yes, we will augment mitral isthmus ablation with RF.
Yeah, thank you.
I have a question. Yeah, okay. Dr. Chen, very nice to see you online again. Yeah, I have a
Yes.
question. Just you know the coronary spasm, the later occurred coronary artery spasm very, yeah, it's very seldom, but maybe we know this is very with a high risk during the follow-up. Do you have such cases?
Good question. So we have a protocol. If we were to pulse the mitral isthmus or the cable tricuspid isthmus, we will give IV glycerin trinitrate (GTN), 1 milligram to 3 milligram bolus. Because the cases are under general anesthesia, so they'll be supported with vasopressors like phenylephrine. So we would give IV GTN before we pulse. For the MI, likewise, we will give, and the CTI. And the RCA, or right coronary artery, is actually near the tricuspid annulus. So if we pulse the ventricular end of the CTI, after we pulse adequately, as we move towards the IVC site, it's far away from the RCA. The risk of coronary spasm is very, very low. So far, we are fortunate. We have zero coronary spasm thus far.
Yeah. I just afraid about the later occurred chest pain. Yeah, maybe several days post the procedure, maybe 1 or 2 weeks post the procedure. Yeah, maybe the follow up for these patients is very, very. We should with very take very care about this case patient. Yeah.
Yeah, I think that's a very fair comment and a good, a real issue. Yes, so far we are fortunate. There were no patients with on the table coronary spasm nor persistent chest pain thereafter.
Yeah.
Okay. Thank you, Dr. Chen. Let's move to our next speaker. Moderator, Dr. Xue, please.
Okay. Our next speaker is Dr. Nai Yiwei from Anzhen Hospital. He is a very young EP guy and very excellent EP guy. Yeah, Dr. Lai will give us a report about mitral isthmus ablation use in the area of PFA. Yeah. Dr. Lai, please.
We cannot hear you.
Excuse me, Professor. 赖教授，您这边的声音太小了，您看是不是调大一点声音？因为我们听不清您讲话。
现在呢？现在可以听见吗？
还是小了一点点，可以再调大一点。
现在呢？
哦，不好意思，赖教授，您可以在这个声音设置里面把您麦克风的声音拉大一点。
音频设置行。基本上，我这里吵，我那个或者离手机是不是？
And excuse me, professors, just please wait for a couple of minutes and We'll finish the adjustment soon.
Uh, 现在可以听见吗？
可以了。
Sorry for the technical problem. I'm going to start today about a very small but is actually a technically difficult issue. Monthly effect
是很小
是啊，
声音还是非常小。
这个我没有，刚才我刚才手机说话，你有点听不见。呃，哎，我现在说话你能听见吗？
可以的，就这样吧，因为要不然这个耽误时间太多了啊。你大点声音讲吧。
好，对对，sorry for the problem. So I'm going to talk about the micro issues.
听不到了，怎么会又听不到呢？你对着，可能你离那个麦近一点。
现在呢？现在呢？
现在勉强可以。
诶，那我为什么一播放换点就不可以？现在呢？现在可以。
现
对，因为你要很用力讲才听得到，你就是很轻。
大点声音讲。
啊，好，
那么放映状态，PPT 放映状态。
现在可以听见吗？
你大点声音讲嘛，你吼一吼。
好，
可以。
我说近一点，就是网络有。So this is the resume of why we do linear ablation. In China, we have conducted a randomized trial in 12 centers around China. In the pancreas trial, we included 498 patients assigned to a linear ablation plus venous muscle ablation versus TBI only. And as a result, we observed and about 10% reduction in the reference rate. And that is why nowadays we insist to do linear ablation in our center. But quite frankly, in the pancreas trial, the mitral ectoplasm and block rate was only 87%. Which means even nowadays, mitral ablation is still very difficult. And the reason lies in the complex in the anatomy of the mitral issue. Nowadays, we can use the high resolution CT to analyze the microstructure of mitral issue. And it turned out that the mitral issue is abundant in epicardial cycle that is carried or protected in the fat tissue. And apparently it is not easy to use any one of the energy, either RF or CF, to penetrate this fat tissue from the endocardial side or the epicardial side. So there is a recent report touching on the conduction recovery of the mitral issue. And they reported that that in 65 patients with previous mitral atrial block, 94 of them have mitral atrial reconnection via the mitral bundle, and 52% of the reconnection was solely attributable to the epicardial block. And even after a venous mitral ablation, the coronary sign of myocardial disease is still very difficult to avoid. And as we now know that the myocardial disease is not tightly attached to the myocardial wall, and actually there is connective tissue in the skin. Also, there are some epicardial bruises connecting the distal myocardial disease and the inferior base of the lateral appendage. And this tiny fiber has also been reported to control aversion to memory entry. So for PFA to achieve durable mitral atrial ablation, we have to overcome all the aforementioned anatomical obstacles. And this is the first attempt for EVG therapy for mitral atrial ablation. It included 45 patients, and the plan to achieve 100% block rate in this preliminary study. However, as for the methodology, you can see that in this study, they only take 2% safety until real world to validate the mitral atrial block. And it is apparently a unidirectional block, not a bidirectional block. And also in the follow-up data, the report nine references and 6 of them were atypically suffered. And in 4 patients undergoing review cases, MI reconnection was observed in all of them. So apparently this study cannot provide very robust evidence that PFA is enough for mitral atrial ablation. And this is another study more recently from Dr. Nashabi. It is very elegant. It included over 200 patients accepting reduced procedure for LAA occlusion. And in this study, mitral atrial isolation was achieved acutely in 100% of this patient. But after a single scanning, 16% of the mitral line recovered. And after 3 weeks, only about 5 of the mitral patients remained bidirectional block. And I think this is another data reported last year's Ablation Society conference from Dr. Bobby, and they included 40 patients. 40 patients expected mitral line ablation using Theratalk or other or calculate. It is very interesting that only less than 25% of the patients had epicardial electrical elimination with endocardial hospital application. And most of the patients finally require venous mitral ablation or coronary sinus ablation to achieve mitral block. So this data tells us that even with PFA nowadays, it is still difficult to eliminate the epicardial fiber, and for the high acute fiber for the bidirectional block cases, many of them were actually had a damming of the epicardial fiber. And this table summarizes the recent study using PFA for MI ablation, and consistently they observed a very high acute block here during the procedure, but also a considerable reconnection occurred in the long-term follow-up. But most of the data nowadays we have are targeted using failure rate. And I want to show you some cases using in our sample we use a context for thinking catheter for microline ablation. And in this case, we do real ambulography before the procedure, but we didn't do apnea infusion. But we didn't do apnea infusion. And then we continue for the CDI in microline, and then the patient got a cardioversion. And after cardioversion, apparently the microline is not lost, as validated under coronary sinus treatment. And activation mapping revealed the breakthrough in the mitral issuance, which indicates the presence of epicardial fiber. After the breakthrough ablation, and after the breakthrough site ablation, we observed a prolongation of the FA interval in this case, and it is if we only focus on the coronary sinus activation, the microline will seemingly drop. There is approximately equal activation happening, but if we carefully look at the electrogram, the future coronary sinus, there is a far field electrogram, and as we can see from the sonography, the view in this patient is relatively parallel with the coronary sinus. So we suppose that this popular method come from the venous marker, and it is from the research, the proximal activation. And not surprising if we insert a microelectrogram into the venous marker, so that the research is proximal activation indicating a residual epicardial involvement. So in this patient, we then do the apnea infusion and the extra interval prolonged, and the microline drops light just after 1 milliliter apnea infusion. And afterwards, we send the negative method into the venous marker, and we keep the patient in the left of the appendage. And both activating of the coronary sinus and in microelectrogram indicate microline. And another case, another question that with Veritop and with Veritop and the actual infusion, this is enough. This is the recent case in our center, and we use Veritop for microline ablation, and the microline lesions really short by apnea infusion of the venous marker. If we do the patients from the LAA side, we use A3 and B3, and we can see the FA interval like that, and empirically we will say the microline may be blocked. But as we place closer to the ablation of the FA interval, that's better. We treat the case so there may be a student we have already done a very, very extensive micro-issuance ablation as well as venous marker ablation. So there is nowhere we can do. We just do some empirical ablation and the base of the ablation appendage, the minimum the cardiac fiber infusion. We know how much is possible, but there is no way for the common and this for future. And 3 months later, this patient come back with a suffer, which indicates a very slow conduction in the coronary family as for infusion and coronary valve. So and all the and this latter was terminated with only 1 shot within the coronary.
So in summary, it is still not easy to secure the microline blocks with PFA alone. And yet cardio conduction remains even greater challenge in the era of PFA. Venezuela administration is still of great value. Coronary sinus ablation is required in many cases, but the safety to do it with PFA remains further investigation, and we are also looking forward to use new energy for the microline ablation. Thank you very much.
Yeah, thanks for Dr. Lai's wonderful lecture. Yeah, and he introduced the experience in Anzhen Hospital and how to achieve the durable mitral isthmus isolation. Yeah, but in the Dr. Professor Qin just reported in Singapore National Center, the mitral isthmus recovery is very, very common in their center. And also in Anzhen Hospital, they have done many cases using PFA energy. So, and they have many experience in these cases. Acidor ablation is also very important in this during the isthmus ablation, and I think maybe use the dual energy cluster, we can achieve higher successful rates in bidirection block. Any questions?
Yes, hi, CK from Singapore. Dr. Lai, it was an excellent presentation. I really enjoyed, your discourse on the mitral isthmus. So my question would be, in your current practice with your insights, if we're using a PFA system to do AFib ablation and you have a mitral isthmus, perimitral flutter, you want to ablate the mitral isthmus. Now, what would be your protocol these days?
Thanks very much for this question. This is very good. And in our center, for all the microline operations, including perimitral flutter, we will do ethno infusion first, and then afterwards, we will do the endocardial ablation, because with the view angiography can help us to understand better the anatomy and the distribution of the coronary venous system to help us to decide where to start the microline flow. And for most of the cases, we are still and the first step will result to the coronary, to the coronary sinus. No matter if the microline is blocked or not, because the residual conduction of the myocardial sleeve of the coronary sinus is still quite challenging. And we should first do some meaningful ablation. And basically, I guess
all right, sorry, it was a bit muffled. So what I hear is that you will do endocardial ablation first, and then you will also...
we're going to do ethno infusion first.
Or you will go straight to ethanoid.
Yeah.
Got it. You will go straight for an ethanol infusion.
Yeah.
Yeah.
Got it. Thanks. Now, just wondering, ethanol infusion, it's a very, very robust and very clear way to get a mitral isthmus block. Do you think with dual energy, for example, RF and PF systems that can deliver dual energy, a combination of dual energy in the area may be effective?
And actually, recently we have tried some dual energy cases for septal pulmonary bundle. And unfortunately, the patient still got the recurrence of the epicardial loose re-entry after dual energy ablation. So I think for the fiber that is protected by the active tissue, we need a more direct way to eliminate it. Either TFA or RF or both may not be effective enough to overcome the insulation.
Thank you.
Yeah. Thank you for Dr. Lai's wonderful inspection and the communication from Dr. Chen, Professor Chen. And Professor Peng, maybe you give a summary for this session?
Oh, sure. No, I think I have learned a lot today. This it's a great honor to be invited to the AHS meeting. Really enjoy it. All the speakers have done a great job. And I hope all these new technology in AFib ablation, I guess I start looking for the ligament of Marshall vein ablation. All right, everyone, thank you very much.
Okay.
Hope to see you soon somewhere.
Okay.
Okay.
And that's all. Okay. Bye bye.
Okay.
Yeah.
See you
Bye-bye.
at least Busan, right?
Okay.
Yeah.